So as our panel mates are coming up, I just wanted to say thank you for the opportunity to be here. It's a real privilege to be among such a great group of people. So I've had a variety of careers. I'm a physician, pediatrician by training, but my first career that didn't work out so well was as a professional baseball player. And the one thing that I learned, well, one of the many things that baseball teaches you is that even though you might be the pitcher and nothing happens until you throw the ball, everything matters after you let go of that ball. And it's about the team and it's about collaboration. And I think that INQRI is all about that. It's all about the team. It's all about people working together. And I really do appreciate that from this program. So I'm going to introduce the panel, and then what I'll do is one of our panel members will give a presentation. I'll ask a couple of questions, and then we'll open it up for some discussion and questions and interaction among all of us. So first, Cindy Corbett is a professor at Washington State University College of Nursing. She's also presently serving as scholar in residence for the Providence Spokane Urban Hospitals. Dr. Corbett's research activities focus on strategies to improve chronic illness self-management and patient safety and have been funded by AHRQ and NIH. Her INQRI project used information technology to help home care nurses more efficiently and effectively identify and resolve medication discrepancies as patients transition from the hospital to home. Linda Costa is currently the nurse researcher for the Johns Hopkins Hospital and an assistant professor at the Johns Hopkins University School of Nursing. She works with the Institute for Johns Hopkins Nursing, teaching evidence-based practice internationally, most recently in Beijing, China. Her current research focuses on improving medication management in chronically ill adults transitioning from hospital to home. Her INQRI project focused on preventing potential adverse drug events during hospitalization through the use of a nurse-pharmacist team to complete medication reconciliation on admission and discharge. And Michele Balas is currently an assistant professor at the University of Nebraska Medical Center College of Nursing. She's a former John A. Hartford Building Academic Geriatric Nursing Capacity predoctoral scholar and Claire M. Fagan postdoctoral fellow. A graduate of the University of Pennsylvania School of Nursing and Wilkes University, Dr. Balas' area of research is focused on improving the physical, functional, and quality of life outcomes of critically ill older adults. Her INQRI project is focused on the implementation of a program of delirium screening, prevention, and treatment. So I'll start with, please join us.
Thank you. I'm Cindy Corbett. I'd like to introduce the rest of our team a little more. I'm at Washington State University in Spokane, Washington, and Ken Duratha is a computer scientist who worked on our team. And Linda Costa and her team were led by herself and Bob Ferroli, is that right, Linda? Yeah, who's a pharmacist. And Michele Balas on her team is also Bill Burke, who's a psychiatrist. So thank you for having us. So as we've heard, nurses represent, and we all know this, nurses represent the largest segment of the healthcare workforce, yet knowledge about nurses' contributions to safe, high-quality healthcare has been limited. In 2005, the Robert Wood Johnson Foundation initiated the Interdisciplinary Nursing Quality Research Initiative to support teams of interdisciplinary scholars to begin to address gaps in knowledge about the relationship between nursing care and safe, high-quality patient outcomes. Interdisciplinary teams explored nursing's relationship to quality care by implementing well-designed interventions with rigorous evaluative methods. Exemplars from 3 INQRI teams were used in our paper to demonstrate nurses' contributions to high-functioning, patient-centered teams to improve safety, quality, cost-effectiveness of healthcare. And the work of our 3 teams focused on a prospective study to improve medication reconciliation at hospital admission, thereby reducing adverse drug events. Linda Costa and Bob Ferroli and their colleagues were funded in the 2nd cohort when the focus of the call for proposals was limited to contributions by nurses and other health team members in acute care settings. The 2nd exemplar was funded in the 3rd cohort when proposals could relate to nursing and other team members' contributions in any care settings. And that clinical trial was completed by myself and Steve Setter and several other team members to identify effective and efficient ways for home care nurses to resolve medication discrepancies following hospital discharge to reduce 30-day acute care use and costs. The third exemplar is a translational study to prevent or mitigate intensive care unit acquired delirium by translating knowledge learned from several clinical trials into practice. That study is being done by Michele, Balas, Bill Burke, and a host of other researchers and clinicians. It was funded in 2010 with the fifth and final cohort, where the focus of the RFA was on translational research and dissemination. Each exemplar in our paper discusses a brief overview of the complexity of the problem studied and why interdisciplinary solutions were required. A description of the research team and the new approach that was studied, implications of the new approach for improving patient outcomes, influencing policy, and contributing to high-value health care were presented. An adaptation of the interdisciplinary research model proposed by Larson and colleagues in 2011 to evaluate improvements in individual health outcomes, health systems, and health policy was used to frame each exemplar and the ensuing discussion. Facilitators and potential value-added benefits to designing, conducting, and translating interdisciplinary research are discussed in the paper. Implications for healthcare professionals, health system, and health policy changes are provided. Based on our experiences, our discussions with one another, and the analysis of those experiences, as well as the feedback of the wise reviewers of our paper, we want to assert that interdisciplinary research offers many strengths, particularly for research related to health system design and healthcare delivery, as compared to research that is conducted in a disciplinary silo. First, our health systems are complex, and they're impacted by health policy, including reimbursement guidelines, the patients and families they serve, institutional policies, procedures, and cultures, and multiple interacting healthcare professionals and other staff. Because of these factors, it is unlikely that research conducted only using nursing's disciplinary knowledge, for example, or any other single discipline, could create a strong impact on care delivery issues to improve patient outcomes. Second, interdisciplinary partners, particularly partners that have expertise in such fields as biostatistics, computer science, engineering, and economics, can make strong contributions to research design and methods, as well as implications that could not be developed by a single discipline. Third, because interdisciplinary research can be conducted in a rigorous manner and with methods that reflect interprofessional interactions that occur in actual practice, such research is more likely to serve as a catalyst for policy and procedure changes within complex healthcare organizations. Finally, when interdisciplinary research includes professionals such as economists, health policy experts, those with communication and marketing expertise, as well as many other fields, the findings are much more likely to be interpreted and disseminated in a way that can influence future healthcare policy. Unfortunately, many barriers exist that challenge the success of interdisciplinary research. Barriers include time constraints, lack of shared values and expectations, lack of shared experiences, goals, and even language. Physical and bureaucratic environments that reduce team members' interactions act as barriers, and the tendency for ineffective team leadership because we just don't have experience in doing so in an interdisciplinary way also is a barrier. Common strategies used by the exemplar teams in our paper to overcome these barriers included, first, engaging institutional leaders during the development and planning phases of the research to ensure that their support was garnered initially and then sustained. And we sustained it in our teams by either involving leaders as members of the research team or by frequently communicating with leaders throughout the research process. For example, in Drs. Costa and Feroli's research, many long-standing employees of the healthcare organization who were clinical leaders and perhaps had 20 or more years of experience at the institution were co-investigators on their study team. A second strategy used by all of us were meeting regularly as a research team. Those meetings served to promote communication, shared values, expectations, and goals, which in turn created excitement and synergy about the research. Meetings also provided a venue for addressing design and methodological issues, which were sometimes solved by novel ideas that could only be generated within an interdisciplinary team. For example, in the research conducted by Drs. Balas and Burke, they needed to implement a coordinated set of interventions that changed the way every single person in the ICU provided care. Each individual had to collaborate on every aspect of the bundled intervention, every day on every shift. Consequently, the research challenged the status quo and led to a novel method of care delivery which was more integrated. However, successfully making those changes to long-standing clinical practices required problem solving during team meetings, as well as frequent interaction with clinical staff on the unit. The third strategy was establishing effective models of leadership, which were somewhat significantly different than what might have been done in a one-discipline research project. The co-PIs of each study facilitated overall coordination and communication among team members, but leadership for certain aspects of the research was generally assumed by the discipline with the greatest expertise in that aspect of the study. For instance, in the research conducted by our team, the pharmacist coordinated medication discrepancy training and consultation for the nurses, whereas the computer scientist coordinated data extraction from the EHRs. And the lawyer, my colleague Dr. Dupler, who's at this meeting, provided expertise in policy implications for our findings. While leadership for varying aspects of the study was provided by team members of a certain discipline, the interaction between interdisciplinary team members resulted in unique, shared decisions, approaches, and outcomes that only came about by appreciating that greater success would be realized through interdependence. The research teams exemplified in the paper succeeded by respecting one another's disciplinary knowledge and using teamwork to create synergy and solutions that would not have been possible without the unique disciplinary skills and expertise of each team member. Interdisciplinary team collaborations, such as those presented in our paper, are examples of creating improved outcomes as defined by Larson and colleagues in 2011, and those outcomes include novel ideas, institutional changes, and innovative practices and policies. The complexity of healthcare and healthcare problems, as well as health systems, requires that we engage a host of interdisciplinary members who work together to provide a seamless web of health services. In closing, although teamwork has always been necessary, the INQRI program ensured that this work within complex healthcare organizations was supported, prioritized, and tested using rigorous designs and study methods. As a result, the INQRI program has provided evidence to address significant knowledge gaps regarding the contribution of nurses and interdisciplinary teams to help shape delivery systems, health policy, and to create safer, higher quality outcomes. That's it.
Thanks very much, Cindy. So let me first, before I open it up for conversation among all of us, let me ask a question of each of you to get some sense of your experience in the interdisciplinary research. So Cindy, let me start with you. And you mentioned about in your presentation about the contributions that some of the team members, non-clinical team members, contribute to research. How about specifically for the work that you did? What was the role of the non-clinical researchers and the contributions that they made to your work?
Yeah, can people hear me? Okay. One of the main non-clinicians on our team was the computer scientist, and he initially from the outset made several contributions to the design and to the methods that we were going to use in terms of he provided a way that we could develop some software to get the computer systems, which even though they were within the same health system, the home health care agency and the hospital, of course, used a different computer system, electronic medical record, electronic health record, and so they didn't talk to each other. So he provided a way to get those systems to provide electronic information from the hospital to the nurses. And then another significant contribution that he made, because he is somewhat of an informatics scholar, is that in our area we have one computer system that multiple agencies, hospitals, and other healthcare organizations use throughout the region, so that although the information is private to each individual agency, they all use the same format and the same software. It goes to the same place. So he was able to, because we had consented these patients and had permission to get their information, he was able to follow up on the patients that were in our clinical trial to see if they were hospitalized at any of 34 healthcare institutions in the region. So without that, we would have probably been only able to follow up on the healthcare institution where we consented the patient, and that was partnering with us. But that made our findings much more robust, because people mostly couldn't criticize it and say, well, they might have gone to a different ED or a different hospital for their readmission. So that was significant. And then Alice, Dr. Dupler, who's here with me, is a lawyer, and in terms of the policy implications and where do we go from here, she and another colleague that is also a lawyer contributed significantly when they looked at the findings and said, oh my gosh, you know, you have 200 and some patients here, and there's 1,400 discrepancies from hospital to home. And that is a huge patient safety problem, and it's probably also a medical liability problem. And so we were able to take advantage of a application from HRQ ARC about medical liability and patient safety. And at first I didn't, thinking of the disciplines and how we communicate, I didn't really understand what they wanted to do. So it was a really good example of how we have to communicate, and we have to really try to listen and just go until we understand. And it took about 3 meetings, and finally I said, oh, now I get it, where we can go with this. So that was, I think, quite significant in moving the research and the findings into whole nother area that can have implications.
Thank you very much. So Michele, if you were starting over again, if you're starting from the beginning, is there another discipline that you would have added to the team, to add to the research team?
Well, that's a great question. And I have to start by saying the intervention that we're doing really does involve almost every different discipline in the ICU. So the nurses have to do certain things, the physicians, respiratory therapists, physical therapists. So everybody is doing part of this bundle that we're trying to do. It also involves people, patients that are medical patients and surgical patients. So from very early on, I knew that if I was going to get a medical doctor and a surgeon in the same room to come to consensus on something that we're going to do for their patients, I needed a psychiatrist. So there we go. We got Bill Burke.
You personally or the whole team?
Well, yeah. That's a great point as well. And also because I knew, we have all these issues that are affecting nursing today, and actually all the healthcare disciplines. But because we're aging, I also got a geriatric psychiatrist. So I hit those kind of 2 issues, early on in the beginning. But seriously, I really thought when this question was posed to me, I really thought from the beginning we really hit it head on the people that we had proposed in our application. And I don't know, it'd be interesting to hear from Mary and Mark if we had the longest list of collaborators and co-PIs on the grant. But on our grant, we did. We had myself, several other nurses, a geropsychiatrist. We had a medical doctor, a surgical doctor, a pharmacist. We had someone who was an expert in qualitative methodology, because our study is mixed methods. We had, obviously, a biostatistician, because we're going to be doing a lot of quantitative analysis. And we also had experts in quality improvement, process change, and things like that. So I really did think we had it pretty well covered. As the study rolled out, and I'm glad to say we just closed the study with 305 patients, but as the study evolved very early on, it became clear that there was a couple people whose voices needed to be heard that we didn't have on. Early on, one of the respiratory therapists at the institution where we were conducting the study really took a leading role in helping me navigate the complexity of an academic medical center. I was new to Nebraska, and so I didn't really have that buy-in that's sometimes so needed to get these studies up and running great. And also physical therapy was invaluable as we developed the protocol together. But even more important than that, and I think Cindy and Linda, you both probably had someone that had computer expertise on your studies. We didn't have someone specifically for that aim, but what I found, because our study was so focused on dissemination and translation, having someone skilled in computers is always a good thing to do. I found IT support in particular I think it would be a nice addition to any kind of further studies I do. I know I'm going to put more money in my budget for IT support. One of the kind of serendipitous things that happened while we were conducting the study is we had the opportunity, we were interviewed by the New York Times about some of the work that we're doing. And from that interview and from some interviews that were conducted with media in the Omaha area, we had a number of families who had patients that were in the hospital who experienced delirium. And I'm sure everybody in the audience, if you've ever had somebody in the hospital setting, you've probably had that same encounter when the person goes in normal, and by the time they get home, they've kind of lost their mind, and you're wondering what happened and where it went. But because of those interviews, we had a lot of family members come out of the closet and start sending me emails and things like that, telling me about their experience. More importantly, we had several people who experienced ICU delirium themselves. Now, these were young, vibrant, very intelligent people. One of them happens to be an associate dean at our college. And I had the opportunity to talk with them and learn from their experience about what it meant to them. And when you hear the story of what it's like to live with new cognitive impairment when you were young and vibrant and had your whole life ahead of you, really touching and moving stories. I think definitely with our next grant, I think it really is key to have that layperson, patient and caregiver perspective on there. In particular, the stuff that we're asking healthcare providers to do in our study is really kind of insane. It's a lot of work, but to hear the patient's perspective on what they think the intervention is going to mean to them and their family, I think it would be great to have a patient or a caregiver in the planning phases of research. I think that would be a great addition.
Wonderful, thank you. And that leads me to my question to Linda, which is in your how important was the selection of the team members and the disciplines, specifically, I guess, the disciplines in developing the study design and the implementation of the study?
So it was an interesting experience for me because I had actually just come to Johns Hopkins Hospital, and 3 of the team members actually were very passionate about medication reconciliation. One was the medication safety officer, who was a pharmacist. The other was the assistant director for nursing quality and informatics, so we did have the informatics connection. And the third person was one of the house staff associate directors, and her responsibility really was to look at the process of medication reconciliation. We'd had Joint Commission come through, and we did have problems with our reconciliation. So that small group actually designed what was our brief proposal, and then when we found out that we were funded, that's when we began to decide how are we going to build this team. We were looking at probably recruiting between 500 and 600 patients to answer our question, and so we found that the most effective way of doing the recruitment was to have each discipline recruit their colleague, and that's how we built our team. So the pharmacist recruited 2 other pharmacists. The associate director for medicine recruited a hospitalist in the hospital, and then we recruited nursing personnel who were directly affiliated with the medical units where we were going to do the study. And that team actually is still together today. We've actually done a couple follow-up studies looking at transitional care and discharge. I guess our unique member of the team, I don't know if he's here yet or not, but he will be here, was our economist. And although I guess we say he's a non-clinician, he really was drawn into the group, Kevin Frick. And the nice thing is he was right across the street from us, so he was very accessible. And I think as we went through the study, we had 2 actual staff nurses who came on to be research nurses for the period of the study. And he was a tremendous support for them because as you recruit so many patients, it does get tiring. And Kevin was always very proactive, looking at data, helping us identify, are we getting all the information that we need in terms of cost, because they also had to track their time in order for us to come up with a cost analysis. So having an economist on the team was really very fortunate for us and really played a strong role. And it was the first time I'd actually worked with an economist before.
I'm glad it was a good experience.
Yeah.
Okay, let's open it up to the group here and see if there are any questions. Please. So the questions on meaningful use and its impact.
So I'll answer that from the perspective of Maryland, which is a DRG exempt state. And we're already beginning to look at loss of reimbursement for 30-day readmission. So we have a lot of activity going on in the hospital and home care trying to bridge liaisons and using a lot of different models within the healthcare system. However, we've implemented some, but we haven't researched a lot of them. So kind of our subgroup is actually taking different aspects of people's work to put together what we hope will be a picture of our 30-day readmission group. But we are in the process of using many tools to look at, can we make a better assessment of who's going home in 30 days and coming right back in. And we have a fairly high readmission rate. We live within an inner city, so we know that it's a major loss for the hospital. So the look at medication reconciliation we've gone beyond the borders, but everyone is looking beyond the borders right now because, yes, affordable care is going to be a huge impact on the bottom line for acute care.
And for nursing care, because nursing care is really not stressed in meaningful use at this point in time. And so without it being stressed, nursing practice will be impacted on the quality of care. They are including quality measures in meaningful use, but they're not saying who's supposed to carry them out.
Right.
Yeah, thank you for your question.
So it's caused me to be reflective about our project, and it seems like when you get to translational research, in fact, the team concept gets a little more complex. So in our situation, we partnered with another organization, the National Database of Nursing Quality Indicators. And so in a sense, we had two teams that were sort of functioning together. And I think that, that raises a whole different set of issues. And when I think about part of why it worked so well is I think that we had sort of clearly delineated scopes of what INQRI would do and what we would do at the University of Utah from the research perspective. But then we did have regular meetings, and at those meetings, I think we tried to be very clear about where the intersections were. So we trusted, for example, they would communicate with all their partner hospitals. They were their members. But then we needed to know what was being communicated, and so we would find, I think, those intersections. And I don't think we had, and my team can certainly add to this, but I don't think we had too many times where we really had unpleasant surprises. So I think there's a lot of advantage in translational work to finding a partner that has that infrastructure, and certainly, especially in the time frames that we had. So I guess encourage us to think about it from the more complex level.
Thank you. John.
John Lumpkin from the Robert Wood Johnson Foundation. Thank you so much for all your work. It's fascinating. I have a question about participating in the INQRI program. I'm going to ask you to be honest. So was this your first endeavor where you were engaged in interdisciplinary research when you joined this program? And then the second part of the question is, having now done this in this way, working with this program, how will that influence research you're going to be doing in the future?
For our project, I'd always really partnered with one of the pharmacists, co-PI, but this project gave us the opportunity to really expand that team and bring in more non-clinicians, and I think that really obviously strengthened the research quite a bit. We, before we'd also worked with biostatisticians, but probably not any other non-clinicians. And based on that experience, everything that's followed has become really more interdisciplinary for us. We've added, you know, in the study that's funded by NIH, the co-PI is a physician. And then just yesterday, we were excited to find out that we had been funded by PCORI. And so on that, we have patients, stakeholders on that team as well, and also a communications person. So really, as Dr. Naylor was talking, I was really reflecting on that and thinking that what a great stepping stone it really has provided in terms of opportunity and how it has helped us broaden even our interdisciplinary focus as we've moved along.
And I was actually new to the hospital when we were funded, so this was my first interdisciplinary research. The team, I think I mentioned, is still together 5 years later, and we're continuing to design and refine our studies. So it's been a great experience. We've added new members, but we've kept all the original members who are still at the hospital kind of working on the complexity. And actually one of our physicians is now the medical director, who's in charge of a lot of our discharge planning work. So it's been a great asset to have her from the very beginning of our studies all the way through to now as we begin to look at how we're going to deal with some of the Accountable Care Act reimbursement.
So I guess I could say this is my first real funded study. I've worked with, being critical care, it's naturally interdisciplinary. So I've had the ability to work with people from different disciplines before, but I would really say that this is my first experience working truly in an interdisciplinary manner where you're producing new knowledge that wouldn't have happened if you didn't work together. I've learned a lot, and one of the biggest things I've learned is to be humble in terms of learning from people and different people's perspectives. So I would say that this is really, it is truly interdisciplinary because we're producing something that no discipline alone could produce. I would say that, in terms of future efforts, I don't think once you do interdisciplinary work, I don't think you can go back to the siloed approach. I can tell you my experience to date. I mean, we've only been doing this, was it 18 months? We've only been doing this about 18 months right now, and the excitement that has been generated from working with our partner institute which is relatively new to clinical research, but the excitement that it's generated in terms of interdisciplinarity is incredible. I have the great opportunity to have a medical student here who's also going for his MPH, who's working with our team now. I'm going to be on his capstone project. I've been asked to be on an interdisciplinary PhD committee. We have surgeons who are now, coming to a nurse to ask how they can write for their surgical conferences. So it's really contagious. I can't envision going back to just, a single discipline doing that. And it speaks similarly to the fact that, I don't think I would ever do a study, and I'm hoping I'm also going to change Bill Burke's mind. I mean, randomized control trial is always the golden child, right? Mm-hmm. But as Mary mentioned in her presentation this morning, they're great. They generate a certain amount of knowledge. But I don't know how you can do a study anymore that just uses one research paradigm, just analyzes something from a purely quantitative perspective. Bill, you with me here? From a purely quantitative perspective, for example, even if you're trialing a new medication for Alzheimer's disease, wouldn't it be great to have the qualitative perspective of what it's like for that patient's family while they were taking either the placebo or the newest, coolest drug on the market? So again, similarly, I don't think I could ever do a study. I mean, maybe get a better funding chance if it's purely quantitative, but doing something that would just use one kind of research paradigm as well.
Thank you. Go ahead.
And everything that you kind of had nurses and the team looking at, did you do anything in particular that really pushed them to do some critical thinking as well? And I bring that about, I raise that because, I mean, is there a piece of this that says, okay, we're looking at this medication is on 2 of these lists but not on the 3rd list, or it's not going home with them or whatever, but is there anything that causes people to also stop and think, is this the right medication for this patient in the first place? And I guess I ask that because I'm beginning to see that I worry that we're so focused on going down the checklist as nurses at least that we're missing the critical thinking aspect.
It's very difficult with the medications, and you're right. There's multiple lists, as Cindy found. It's very difficult. We focused our home visits on people that were on at least 6 medications, and so it was very confusing, multiple lists, missing medications, high-risk meds not there. So I think bringing that back to the nurses and saying, is there a way we can back this process up to take a look at what can we do to make it more effective? And I don't have the answer to that. I see a lot of the problems now. I don't really know the solution. We have gone to an electronic medication reconciliation list, and we piloted that during the research, and that actually has been much more effective because now we're using one list, whereas before the nurses did a list, the physicians did a list, and the pharmacists did consultation. So I think that's probably been the most effective use of combining all of our knowledge and critical thinking. The nurses are picking up these discrepancies, and they're concerned with discharging people when it's not really clear that they totally understand their management. But I don't have the answer to the puzzle yet, but I can tell you the nurses are aware of it. And one part that we did with Mary Ann, and I'm sure she'll be talking tomorrow, is we did look when we were doing the discharge readiness assessment at how many medications the patient was going out on, and did that become a significant predictor as well.
Please.
Jack Needleman from UCLA. There have been 2 themes to the conversation we've been having. One is about creating interdisciplinary research teams, and given the nature of the projects that you're involved with, creating interdisciplinary care teams. And I'm just wondering, for each of those, what have you learned about the challenges of changing the way nurses are integrated into the work? In your research teams, what have been the challenges for nurses in becoming members of interdisciplinary research teams? And as you've tried to re-engineer care, what have been some of the challenges of changing the work environment to change the nature of the interaction between the nurses and other members of the teams you've been trying to create?
Okay. Wow. Okay, so I'm trying to think of what part of that I can begin to tackle. The nurses actually have been very invested in the work in medications. And not just the research nurses that we did the original work with, but the nurses on the patient care units. They are in more communication, I believe, and we have house staff on most of our units, with our house staff teams, in actually taking a very proactive role to the point that they are stopping discharges at this point if they feel that there is a problem with a patient going home who is not prepared. So their voice is becoming more important and recognized, and I think that the medical staff is supporting this because we know, and we're watching and we're getting ready to analyze our results, but we know that we're seeing patients coming back in that nurses identified as not being prepared, and they're back in within 48 hours to the emergency room or they're readmitted. And so I think we're just beginning to say this is the beginning. The pharmacists are really helping us with consultations, and the nurse will ask the pharmacist to come up and evaluate a patient. And the pharmacists have been great in looking at medications and trying to work with our patients in understanding these complex regimens that we're discharging them with, as well as bringing them back into pharmacist-managed clinics. So I think we're just beginning to work with the care teams, and it's such a complex environment. It's really hard for them to focus on one thing, but because of these complex medical patients, we're actually finding that they're devoting a lot of time to looking at this discharge process.
In terms of, I would just say in terms of home health care, our study mostly took place in home health care, and nurses are really the central discipline in home health care, and so I don't think it was as hard to maybe think about how they would integrate. But interestingly enough, based on our findings, then the home health care agency took that information and said, wow, we really need to track these medications better and make sure we follow up on any discrepancies until we have an order that sets it right. And part of doing that then had implications for their therapy staff, who said were kind of nervous about that, and just then they sort of went through with all the staff, how do we integrate the medical record better so we're all charting? So similar, I think, to having a multidisciplinary protocol. When you look at the medical record, oftentimes people chart in their own little places, and so they were trying to figure out how could they integrate the medical record better to have this communication, and then to ask for consultation from a pharmacist and or a nurse when they needed it. So that was one of the practice implications that came out of our research in terms of trying to do a better job with teamwork.
In terms of nursing and research, I'm going to take it from the perspective of the clinical nurses that I'm working with and their participation in the research project to date. So one of the things we tried to do, was set up a series of focus groups so that the nurses, interdisciplinary, again, everybody invited to the same focus group, to have the nurses tell us what they thought. While we were developing the protocol, we wanted to get their opinions on, does this work for you, does this not work, what do you find beneficial, stuff like that. We struggled with attendance at the focus groups. I think we at the beginning we probably had about 6 of them, and our attendance was pretty low. And we're doing it in 5 different intensive care units, so it's several hundred nurses. So there was a little hesitancy on their part to take part in these focus groups, which on my perspective is totally frustrating, because the bundle itself has a lot of implications in terms of nursing workload. We're going to be asking the nurses to do triple, if not quadruple, the amount of work they've done before. Why? Because it's the right thing to do, and it'll help patients. But it literally is going to triple their workload, getting people up out of bed and walking, shutting off their sedation, not tying them down to the bed, triple the workload. All we wanted them to do was to find their voice. Come and tell me these things. Our patients are 400 pounds. It's impossible to get them up. So I could publish those things so that administrators could find, there'd be some strength in their words so that administrators could see just how difficult this is and how much manpower it's going to take to make successful. I just wish they would have used their words. It's been getting better. Over the last couple groups that we've had much more attendance, and the nurses are much more vocal now. But it's been a struggle helping them to use their voice. So what I found is they've been trying to do these interdisciplinary rounds for several years at the medical center, and they've just given up. They're at the process where they're they've done everything they were supposed to do. Do they have a central line? Do they have a Foley? And they were doing these things that they wanted to discuss with the physicians on rounds, and they came up with paperwork so that all of these important issues are addressed. They filled out the paperwork, and nobody did anything with the paperwork. So guess what nurses are going to do? They're going to stop doing the paperwork. If you're asking them to do something that has no impact on care delivery, it's stupid to do the paperwork. So they've given up from filling out those things because they've been beaten down so many times in terms of trying to make this happen and not having it happen. So helping them find their voice again is pretty important.
Marcy Harris, University of Michigan. I was a co-investigator with Jack, and I'm sitting here trying to figure out if the issue is Jack or the multidisciplinary team here. Jack's awesome. but I'd have to say, honestly, I had been an administrator in a nursing environments with large operational groups for many years prior to this. And had done other research, but I don't think I was ever had previously you're speaking to the preparation and the leadership role one has to assume on an interdisciplinary team when you're a co-PI. I don't think I was prepared for that at all. I don't, I think in doctoral programs now we're all prepared to lead leadership or research teams, but I'm not sure we are, I don't want to say it negatively. I think there are lots of opportunities to provide more training experiences and maybe learn off this initiative on ways to prepare nurse researchers to really engage meaningfully as co-leaders in research efforts. I thought it was kind of a challenge, and it wasn't just Jack.
Thank you. Any other thoughts on this line? Yes.
Go ahead.
Oh, sorry.
That's okay. I'm Lynn Soban from UCLA and the VA in Los Angeles. What I was thinking, just listening to your comments about the kinds of folks that you collaborated with, and then also knowing some of the other non-nurse contributors to INQRI projects, I think it might be really beneficial to have a very tangible article that's written about the kinds of other disciplines outside of nursing and the contributions that they can make to nursing research. And it has to be pretty simple, but I actually think that even from talking to you, I'm not getting a real clear sense, or listening to you, of what was their contribution and how did they, what theoretical models did they help you think about? What other ways of thinking about your problem did they open you up to? And I think that a paper that describes that could actually be a really important paper to the field. There's a paper in the packet that sort of gets at that, but I think that it's still not quite rich enough to me in terms of those other folks' contributions. So I mentioned that as a suggestion for a really cool paper that I think could really make a difference to the field.
Thank you. Yes, in the back.
Hi, my name's Catherine Rule. I'm from the Association of Women's Health Obstetric and Neonatal Nurses, and thank you all for your excellent presentations. I'm wondering, in your organizations, were there other units who either perhaps got grants to do research, interdisciplinary research, or might have even, short of that, adopted certain elements because they were inspired by what you were doing?
Anyone on our panel?
Well, I don't know if it was really our study that inspired it, but I think partially, and also the fact that everybody's looking at transitional care and how we can do it better, and there's some funding mechanisms through CMS for care transitions. And so the hospital system that our research was done in did develop a team. They provided some internal funding for how can we do better care transitions, and then subsequently applied for the care transitions funding from CMS. So I think it does carry over into the hospital when you're really, or whatever healthcare organization you're really integrated in. And it was sort of an amazing experience, I think, with healthcare reform, that we're starting to see people that are practicing in the hospital talking to people that are practicing in the community. Because as those people came together for care transitions, the people from the hospital said, I had no idea that this organization even existed and all the things that you do for people in the community. And so I think that is going to be a real benefit of what we're seeing with what's going on in healthcare. I don't know if that answered your question, but.
I think what we've seen is that we're beginning to see within units small tests of change, and we're seeing it very frequently among the teams. So it may not be related particularly to medications, but we've seen a lot of work emerging in the quality improvement area. And I think that's probably, we're beginning to actually put patient safety nurses at a unit-based level. So in our critical care area, we may have one nurse who has a 20% funding to begin to look at their actual practice within the team. And I think that's something that's taking place on several different areas and being fostered by a safety institute that we're affiliated with. So it's really not within the research realm right now because it's a unit-based initiative, but I think it's incredibly encouraging to see these unit-based multidisciplinary teams beginning to identify areas of practice that can be improved and moving forward through quick, rapid cycle change to implement. And I think the thing that's been most supportive is that our executive team actually goes to these units every month to hear what's been going on, what's the next way you might harm patients, and what have you done with that. So I think that's where I see building and enlarging the interdisciplinary teamwork at the unit level.
So I think I can say on our campus, again, we've only been doing this for such a brief period of time, but I think the biggest impact that we have is that people are actually seeing clinical research being conducted by an interdisciplinary team. I think there's also been a change in the way people define translational research. Previously, I think it's been pretty heavily focused on that like bench to bedside kind of issue as opposed to clinical trials to practice. So I think that's been a major change too since we've started this. But there's been a lot of excitement, and I see a lot of, just from an observational perspective, I see a lot of people talking to people that they might not have before, which is always a good thing, and coming up with ideas in small group settings.
Thank you. Other questions? Yes.
Kieran Phibbs, Palo Alto VA and Stanford. For the ICU study, it struck me, you said you were talking about this huge increase in the nursing workload. And how did you actually get that accomplished? Okay, if either there was no increase in the nursing hours allocated, and then that came out of something else, and it could have had adverse impacts elsewhere, or you succeeded in getting the nursing hours of care increased, or was it that, well, you showed that, well, we're going to increase our nursing hours here, but we're going to prevent here so it, can pay for itself, and, because the pushback, I can see the pushback from nurses, oh, we'd love to do this, but we don't have time. And how did you actually get this translated into clinical practice?
All great questions again. First of all, little secret, we are not at 100% compliance. So again, not even close. We had such a short period of time in terms of the grant. We had to go through the IRB. And so by the time we literally got through the IRB, got all the researchy stuff done, and then we had to get all, a policy through and then get it up and running into everyday practice, there's a great opportunity for improving what we're doing. But you hit on, I think, probably the biggest thing that's impacting ICU nurses or ICU providers on a daily basis. We have all of this wonderful evidence. Getting it into practice, so very important, but something's got to give, right? If we're asking our nurses, there was a wonderful study that came out about tight glycemic control, all right, decreases mortality. Pretty important, I would think. However, it went to the extreme where then we were asking our ICU nurses to do blood sugars every 1 to 2 hours to keep it in this ridiculous range of like 60 to 110 at some point or something like that. Where was the questioning of what is the nurse not doing because now she's doing blood sugars every hour? I fear the same thing with what we're asking nurses to do. Totally right thing to do, but again, so much work. What are they going to have to give up? And that's why it comes back to, again, please let me hear your voices and tell me these things. So in terms of how are they doing it? So they have not increased FTE, obviously. They're going to make it happen. What I've been told is they're going to make it happen with what they have. And that may mean relocating non-nursing hours, so getting more physical therapists into the intensive care unit, redesigning how the respiratory therapists practice, meaning that they won't be pulled from unit to unit. So they're going to try to do these things cost neutral. Get these things up, yeah, right, cost neutral. But the hope is that if you can, decrease, what we're hoping to find is we're hoping to find some effect, because we do have a quantitative aspect to this study, which is, does it work? We're going to have to answer that question knowing, does it work with, maybe only 20% adherence to the protocol itself. But so changes in workload to other disciplines, hoping to pick it up. And hopefully, nurses saving some time and some of their energy in dealing with patients. If we could decrease people being confused and delirious, it's very hard to take care of those patients. Maybe if the people have their minds, they won't be so hard to be taken care of. So, great point. That's always the struggle. What's got to give? What evidence is the most important? We have a pharmacist who's going to do like an economic analysis of, how much cost savings we have in terms of money. Mary gave me the word. I didn't know. I was going to ask Mark. I knew I needed somebody with health economy because we do have to do that. Like if we can cut ICU length of stay 2 days, give us more nurses, and maybe we can even cut it more or whatever. But that labor economist aspect of it. So looking at the nursing hours per intervention, what it's costing us. I wish I would have done, you can't do everything with this study, but that is such, and maybe that's the next step, is looking at the cognitive complexity, the labor intensity of this intervention, and weighing the cost benefit of that.
Thank you. Other questions? Yes.
Let's say you were designing a grant program that required interdisciplinary research team. I'm wondering, from your experience, what you would like to see, what you would put into that grant program in terms of the call or the way it's structured or anything to really facilitate this work and help the research project really get done and be relevant to making an impact.
I have one thought.
We'll go with it.
That's a tough question, right? I think the first thing I would do was to actually look at the problem that they're proposing to study to see if it really does require interdisciplinary solutions. I think that's number one. And to look at the argument why one discipline can't do it alone. I think that would be something that I would totally focus on. And again, getting back to that mixed methods, seeing how, to answer that question, does it work? But, in a complex system, how does it work? So I would look at those two things. That's my shot at it.
I think that's good.
Maybe the audience has.
Great. Yes.
So one more question. What feedback have you gotten from your consumers or your patients?
We've done actually we've done two things. We've done post-discharge phone calls, we actually asked when we were doing one of the studies if we could call the person after they went home. We were just going to see if they'd been in the emergency room because we don't have connective systems throughout the city. And so we thought it'd be interesting to see, well, out of the 300 people that we entered in this study, how many actually would opt in the research for us to call them? 95% of the patients opted in to be called, which I thought was absolutely amazing. So that showed us that people want to talk to us after they go home. And we were able to contact a pretty significant number of those individuals after they went home. This study that we actually did was not particularly focused on medication, but on discharge preparation. And so not only did we just really wanted to find out if they'd been to emergency rooms, but we found out everything else when we called them. So we actually were able to feed back to the units, but the consumers, and especially the ones that I visited in the homes, it's incredible stories. There's just too many of them to even begin, but they are so grateful to have someone come in and try and help them. We do everything from fill pill boxes to call physicians, and I wish there was a way that we could extend all of our care to the patients after they leave, because it's an incredibly rich area for nursing, and certainly with the support of the physicians and pharmacists that we've used that help us if we're in the home and having a problem.
So unlike my colleague Cindy, congratulations on the PCORI. We did submit a PCORI grant. We've been very active this last year that we proposed to address that very issue, because in the end, that's what matters. So getting the patient and their caregiver's perspective on, okay, we did this intervention, what you think about it? Was it too much for you? What were your thoughts with it? Did it help you in the long term? Did the patients that, what was it like to go through these, having your sedation shut off, getting up and out of bed while you're on the ventilator, really getting that patient and family caregiver perspective. Unfortunately, we weren't as successful, but maybe next time. But that is one of our that's the next step. We care what happens to them in the hospital, obviously, if they live or die. We want to know, does this help them in the long term in terms of their cognitive ability, their function, and their return to their quality of life? Can they get back to their spouses and their caregivers with the same kind of capacity they had before? So that's kind of the next logical flow, I think, of where we're going to be going.
And in our study, we followed it up with the study from AHRQ ARC, and we actually interviewed 10 focus groups. We had 10 focus groups of stakeholders from all different disciplines, including patients and family members, which was very fascinating. And all of them, the patient and family member ones were probably the most fascinating, and they talked about the chaos at hospital discharge and why they don't understand what they're supposed to do when they go home, and how all that paperwork we make them sign really means nothing to them, and they don't actually look at it once they get home. And so, similar to what Linda is doing, they all really said what is needed is somebody to contact us after discharge to the person. And so I think that's probably the lesson that we learned, is that people do appreciate this, and if we listen to them, we might be able to figure out how to do things more efficiently and effectively.
Thank you. Any other thoughts, comments? Yes.
Pat Sloan, as an old public health nurse, I cannot tell you how much I appreciate hearing what you're coming up with in terms of the results. It's not that we haven't known this, but we haven't proved it before. Thank you so much.
Thank you. I think what I'm going to do is ask Cindy to make some closing remarks for us, if you would. Is it?
No.
Oh.
Michelle's going to.
I'm sorry.
I'm going to do the closing remarks.
All right.
So Cindy, Linda, and I'd just like to say, first off, thank you for giving us this opportunity to hear your thoughts from such a prestigious audience. Also, a special thanks to David for moderating the session. You did a great job. As any grantee would acknowledge, this presentation and our upcoming manuscript, the manuscript itself doesn't seem like it's ever going to end, does it? Oh, my goodness. None of that would have been possible without the assistance of Heather Kelly. I think any grantee would acknowledge that. Heather, thank you so much for all you do. Keeping us on track. Very, very important. Most importantly, we really do want to acknowledge everyone at the Robert Wood Johnson Foundation INQRI program. We are particularly grateful for the program's co-directors, Dr. Naylor and Dr. Pauly, for their vision, for their enduring commitment to advancing what we know about nursing and its effect on quality, and for their truly transformational leadership. We thank you for that. This team, Mark and Mary, they've accomplished an incredible amount. They just gave you little slices of it in the beginning in such a short period of time. Mark and Mary, we thank you for all your wisdom, support, and guidance. These two very special people really do epitomize what truly successful interdisciplinary collaboration can achieve. So thank you for that. So closing thoughts on interdisciplinary research. I think we're really thinking about three separate questions. Number one, was it easy? I don't know if you've got this from our talk today, but clearly no. It's actually pretty much hard work. There's a number of challenges when conducting interdisciplinary research. Something that we didn't ironically talk too much about was the time constraints. Just how much time it takes to do this kind of collaboration. You're talking time in the pre-planning stage, but more importantly, just time together. You know, those precious moments that I've had with Bill and other members of the team where we could just sit for 2 seconds and think, wouldn't it be neat? Or we never thought about, oh my God, apathy, great concept. So stuff like that. So that time commitment, very, very important. One of the things that we found, it is a really important thing to think about is, do you have team members that really do share the same values and expectations and goals of the research? And those physical and bureaucratic environments that make it really hard to do that interaction on a daily basis. Good news is Bill's office just moved a block closer to mine, so it's not exactly as far away. One of the other things that I think that is kind of a takeaway is it's hard to decide who to know to put on the team. It's great to have this opportunity to think, oh, geez, I should have had one of those labor economists. One of the labor economists be involved to figure out those staffing issues, those, the work value issues. But it's tough to know before you start the program on exactly who is one of those members that, oh, I wish we would have had them on the team. I think the next major question is, what could help? So what we found is really careful planning to the best of your ability. When you're planning the proposal and things like that, it's very important about thinking in terms of team member selection. Regularly scheduled meetings never hurt. I just scheduled one this week where we're trying to get everybody together again. Next grant, I know that I'm going to be doing that on a monthly basis. Bill, don't run away, but yeah, that's going to be happening. But regularly scheduling that time together. There really are some major changes in education that need to occur, and it's very exciting to see, coming from the academic world too, that interprofessional education is happening. One of the things we didn't get to address is, how do you get, have graduates from our programs that really have that specific discipline-specific knowledge, but yet also have the exposure to that interprofessional collaboration. We don't want to lose the disciplinary knowledge. And if anybody's been teaching lately, we don't have enough time to help our students learn everything they need to learn to be safe care providers, yet alone adding this layer on top of it. So it's another great topic for a paper. Methodologic rigor and the use of mixed methods, really answering the question from two different perspectives. Again, I'd have to say humility is key. I think I know everything there is to know about ICU-acquired delirium and how bad it is, blah, blah, blah. All I have to do is spend 2 minutes with Bill and our medical student, and they start talking about the neuropharmacology of the different antipsychotics, and I blank. So really acknowledging that you can't know everything, that being able to have flexible leadership and giving people the ability to be leaders on the team when, having that leadership flexibility in terms of answering the question that comes up at hand, who's going to take the lead on that, because we cannot be experts on everything. I don't know if you guys would agree, I think it takes tons of energy, tons of flexibility, and a ton of positive attitude because, as in any time you get people of different perspectives together, sometimes there's a tendency to have that negative attitude. So really staying positive, focused, and having a lot of energy is beneficial for this kind of work. Willingness to use your voice, or I like to tell my toddlers, find your words. Getting people empowered that have not been traditionally empowered to use their voice, really trying to get them to speak up so we can hear them. And always, again, coming back to money. This kind of work's going to take a lot of money. It's expensive to have 15 co-PIs on a grant. But the benefit of having, literally, I think we have 8 or 9, but the benefits of having the ability to work and get those perspectives in the planning, analysis, and dissemination phase is so important. But then that's, that's your whole budget is on salary. So, question: what's the future? I think there'll be a really big push for interprofessional protocols and practices. Obviously, that's the wave of the future. We're going to need the resources to ensure that the interventions that, particularly these really important medication reconciliation interventions, how do you make them happen after the research goes away? To have that fidelity, like when I die, who's going to make sure that this stuff's going to go on? Ways of following outcomes, finding out what outcomes are most important to our patients and our family, redefining, maybe, mortality and those quantitative things aren't as important as some of the other, what was traditionally considered soft variables, and those workload issues. Linda Aiken is another one that can never die because, as I said, when we were talking about the evidence, the last 5 to 10 years, in particular for staff nurses, has really seen a major change. So even that great research that we had 10 years ago, I'm not sure it's applicable anymore in this setting. I mean, we're getting new evidence that we're required to put into daily care every day. Wow, a lot of work there. So finally, the last question, would we do it again? I think the resounding answer to that is yes. I don't think we can ever go back. And I hope you can see some of the excitement and all the positive, particularly with the people that came before me, all of the great work that they've done in getting that evidence out there and making a difference in patients and their families' lives. So thank you.
So a huge, huge thank you to the trendsetters here who, you recall that I said we're going to set the bar as high as it can possibly be, that it will be a transformative experience, and we could not have had a better start. So thank you, David and Cindy and Linda and Michele, for your passion, for your commitment, for your honesty, and for making sure that our reception in the Mount Vernon room is
on time.
On time and filled with conversation. Really, really excellent, excellent. Thank you.